right? So the first one, right? So the first one is ADH, right? So the first hormone that we have is ADH. So what is ADH? So basically, ADH is antidiuretic hormone, right? And what does ADH do? So ADH is gonna increase the absorption of water in your body, right? So whenever there is an increased ADH, it is gonna increase the absorption of water throughout your body. Now, the main thing that is important here is USMLEs want you to know, wanna know what is the point, at what point ADH works to increase the absorption of the water, right? Because there are a lot of points in the body where at which ADH can work, right? So ADH is going to work on the distal convoluted tubules, right? Now, the second thing that is important here is another drug also works on the distal convoluted tubule, and it decreases the absorption of water, right? So what is that drug? So if you look at that drug is going to be a thiazide diuretic, right? So if we look at thiazide diuretics are going to act on the distal convoluted tubule, right? And they're going to decrease the absorption of water. So these work almost in different ways to each another, right? So thiazide diuretics are going to decrease the absorption of water at the distal convoluted tubule, whereas ADH is going to increase the absorption of water in the distal convoluted tubule and as well as the collecting ducts, right? So when it will, now, one important side effect of antidiuretic hormone is that this is very important. Whenever there is excess secretion of antidiuretic hormone, so whenever you are having antidiuretic hormone and there is excess secretion of antidiuretic hormone, that can cause hyponatremia in the body, right? Because antidiuretic hormone also decreases sodium levels, right? So antidiuretic hormone are gonna decrease the sodium levels. So they decrease the sodium levels and you are gonna have hyponatremia. That is one of the side effects of the antidiuretic hormone. Now, why is this thing important? This thing is important because there is a condition which is known as the SIADH, right? So SIADH stands for symptom of inappropriate antidiuretic hormone secretion. So we have a disease which is known as the SIADH. So whenever a patient suffers from SIADH, there is going to be increased amount of ADH in the body, and then that, so USMLEs can give you a question. They could ask you that a lot of people, a person comes to you and that person is having increased amount of ADH in the body, and as a result, which are the following physiological changes you can see in the body, right? And then they could give you water levels, right? So water levels are going to be increased, right? Then they're going to give you sodium levels, and there could be arrows. So sodium could be increased, sodium could be decreased. So sodium is going to decrease, right? And then they're going to say water absorption at the proximal convoluted tubule, right? So at the proximal convoluted tubule, the water absorption is not going to change. It's going to remain the same. And then there would be water absorption as the distal convoluted tubule, and it's going to be increased, right? So this is how regarding hormones you can be tested, right? So they could be so keep this in mind, right? So you have to know where do these specific hormones work, right? Now you have to know the regulation of these hormones as well, right? So what are the things that regulate ADH, right? So what are the things that regulate ADH? This is important. The number one thing that regulates ADH is hypovolemia. So whenever a patient is having low blood pressure or low blood volume, that patient may be getting ADH secretion, right? Second thing is pain, right? Now, why is this thing important? Why have I marked pain? This thing is important because if a person comes to you and that person is running in a marathon, right? So for example, if a patient comes to you and that patient say, I have been running the marathon for the last 3 or 4 hours, so what changes can you expect in this person, right? So they could ask you, what changes can you expect in this person? So the changes that you could expect is that this patient could have pain, right? So whenever this patient would have pain, as a result, this patient's ADH levels are going to be increased, right? And as a result, water reabsorption is going to be increased, but his sodium levels will be low. Now, why is that important? Because whenever a patient is having acute hyponatremia, whenever the patient is having very low sodium levels, the patient is going to have nausea, vomiting, acute mental status changes, right? Now, that was the first thing. Now, the second thing is sometimes we can have a deficiency of ADH, right? Sometimes we can have two things. So, one could be the ADH deficiency, right? Sometimes you can have a deficiency of ADH, and sometimes you can have resistance to ADH. These are the two different things So you can have ADH deficiency or you can have ADH resistance. So whenever you have ADH deficiency or ADH resistance, the body is not gonna the body is not gonna absorb water anymore, right? The body is not gonna absorb water anymore. So now here we come against another concept which is known as the plasma osmolality. So now we have a concept which is known as the plasma osmolality. So what is plasma osmolality? This is a thing whenever you are solving any question in the UL, 60 to 70% of the questions are going to mention plasma osmolality, right? 60 to 70% of the questions are going to mention to you plasma osmolality, right? So what is plasma osmolality? I know most of you would have seen this thing in your medical school exams. So plasma osmolality means the concentration of nutrients or the concentration of the solutes in your plasma, right? So that thing is known as plasma osmolality, right? And below 295 it's considered normal, right? To 295 milliosmoles per liter it's considered normal. Now whenever a patient is having increased amount of ADH, so if it's 275 to 295 it's considered to be normal. Now if a person is having increased secretion of the ADH, let me check if there's any question. Okay. Now, if a patient is having increased amount of ADH secretion, right? So this is important. This concept is very important. If a person is having increased ADH secretion, the body is gonna absorb more water, right? When more water is gonna be absorbed, the solutes are gonna get diluted, right? This is very simple. The solutes are gonna get very diluted. So just imagine you are having a water glass, right? And you have, if half filled, and you enter in it 10 grams of sugar, right? So you put 10 grams of sugar in it, right? And after that, the next thing that you are doing is that you are adding another glass of water and you are filling it in. So if the concentration of sugar below was 10%, now it's going to be 5%. The same is the concept with the plasma osmolality, right? So whenever you absorb more water in the body, whenever you are having increased ADH, the plasma osmolality is going to decrease, right? So it's going to decrease to 260. So whenever a patient is having a symptom of inappropriate antidiuretic hormone secretion, SIADS, that person's plasma osmolality is going to be decreased, right? Now the second thing here, what is the second thing? What if I say to you that patient is having a problem in which the patient cannot absorb, so that patient's ADH is not working, the patient's ADH is decreased, or the patient is having resistance to ADH, then that condition is known as the diabetes insipidus, right? This patient is having a condition which is known as the diabetes insipidus. Now we are not going to go into very much detail of this condition, because when we are going to start the endocrine pathology, we are going to discuss diabetes insipidus and SIADH in detail, right? But now right now we want to just look at how do the ADH works, right? So now the next thing that is very important here is, whenever you don't have ADH, the water levels are going to decrease. And when the water levels are going to decrease, the solutes are going to get concentrated. And the plasma osmolality is going to go to 310, right? So whenever the plasma osmolality is very high, think of it as the ADH is not working properly, right? Whenever the plasma osmolality is high, think that the ADH is not working properly. And whenever the plasma osmolality is low, think that the ADH is working very fast. Now that is the first thing. Now what's the second thing? The second thing here is that it's an important clinical note, is that whenever a patient takes alcohol, right? Whenever a patient takes alcohol, that is going to decrease the secretion of ADH, right? So alcohol is going to decrease the secretion of ADH. And when the secretion of ADH is going to be decreased, now what is going to happen is that the patient's water is not going to be reabsorbed. The patient is going to have polyuria and dehydration, right? That is why whenever you come across a patient of alcoholism, that patient is going to have dehydration. And now they could ask you why. So now they could ask you that a person comes to you and that person is an alcoholic, and that now they won't directly give you the person is alcoholic. They may say, so now remember, a very good marker of alcoholism is GGT, right? So GGT is a blood marker of alcoholism. If a patient is having alcoholism, he may have increased amount of GGT. So GGT stands for gamma glutamyl transferase, right? So they could give you a person and they could say that a person comes to you and that person is having increased amount of GGT in the blood, and at the same time the person is very dehydrated. And now they could ask you, what is the pathophysiological mechanism that causes this dehydration in this person, right? And then you are gonna say that, what the hell in the world is this question, right? What the hell in this? What is you world? What is you world even asking me, right? So they are basically asking you, what is the mechanism of ADH secretion in alcoholism? So whenever you are having alcoholism, the ADH levels are going to decrease, and whenever the ADH levels are going to decrease, you are going to have polyuria and dehydration. And then they could even ask you further, where where is gonna the water be not reabsorbed, right? So the water is not going to get reabsorbed at the distal convoluted tubules and at the collecting ducts, right? So this is how this is going to present you, right? Yes, it works in the collecting duct as well. Okay, so Dr. Laiba, what was the concept in marathon runners, right? So remember, ADH is also secrete whenever a patient is having pain, right? So pain is a very strong stimulator of ADH, right? So whenever a patient who is running marathon, he's going to have a lot of pain, and at the same time, that patient is going to have a lot of hypotension and dehydration as well. So whenever you are having hypertension, hypovolemia, dehydration, and pain as well, a lot of ADH is gonna get secreted. And when a lot of ADH is gonna get secreted, you are gonna have hyponatremia, right? And when you are gonna have hyponatremia, you are gonna have nausea, vomiting, acute mental changes, and so you're gonna have acute mental changes, you are gonna have confusion, you are gonna have all of these changes. And this concept is known as the exercise induced hyponatremia, right? This thing is known as the exercise induced hyponatremia. So this is the whole pathophysiology behind exercise induced hyponatremia, that a patient is running, there is hypovolemia, there is hypertension, and all of those things are present, and the patient then gets hyponatremia, right? Okay, so is anyone have any other question?
Yes, doctor.
Yes.
Is it the hyponatremia that makes one to drink a lot of water?
Yes, exactly. So whenever a patient is having hyponatremia, the patient, so remember, salt levels in the body are a very strong uh, indicator for thirst, right? So whenever you are having low amount of salt in the body, whenever you are having low amount of sodium in the body, the patient is going to have an increased amount of thirst, right? So whenever you are having a hyponatremia, you want to drink more, so that is why the patient is going to drink more water. But paradoxically, when you will drink more amount of water, the salt is going to get even more diluted, right? So you are going to get more hyponatremia, and this vicious cycle is going to start, right? So in the latest guidelines of the US healthcare department, they say that whenever a patient is going for an exercise or a marathon or a long distance exercise, drink only in moderate amounts, right? You do not have to drink to up to your fill. Why? Because if you're drinking up to your fill, you are gonna dilute the sodium levels even more than before, right? And that is gonna cause a lot of problems, right?
Hmm.
Okay. Now, so this was ADH, right? So now one more important fact about ADH is that ADH does not only works on the collecting duct, right? So it does not only cause the water absorption, it also causes. So remember, ADH. So there are two ADH receptors in the body, right? Now, I want you guys to annotate this thing on your first aids as well, because it's not present there. So there are two kinds of ADH receptors, right? So the number one ADH receptors are the V2 receptors of the ADH. Right? So these are the V2 receptors of the ADH. And how do these receptors work? So when ADH binds to the V2 receptors, and where are these V2 receptors present? They are present in the distal convoluted tubule and the collecting duct. So whenever ADH works on these receptors, you are gonna get two things, right? There would be aquaporin channels, right? So there are gonna be aquaporin channels, and these aquaporin channels are gonna get. So if this is the cell of a collecting duct, right? So this is aquaporin and it's present here, right? Now if ADH starts working, this aquaporin channel is gonna go here, and it's gonna form a channel for the reabsorption of water like this. So this is all happening due to ADH, right? So this is how ADH works in the collecting ducts. But at the same time, ADH also works on the V1 receptors, right? So what do the V1 receptors do? So V1 receptors are responsible for the vasoconstriction, right? V1 receptors are responsible for the vasoconstriction. So ADH also increases the blood pressure, but this is going to happen when the ADH levels are very high. So when the ADH levels are very high, ADH is going to act on the V1 receptors also, and it's going to increase the blood pressure, right? Now, why is this important? This is important that because whenever we are having a septic shock in the patient, right? So whenever we are having a septic shock in the patient, the first thing that we are going to do is we are going to give the patients IV fluids and antibiotics. If that does not solve the problem, we are going to give the patient epinephrine, right? And if even epinephrine does not control the blood pressure and if does not increases the blood pressure, then we are going to give the patients ADH in high dose. And when we give patients ADH in high dose, it's going to act on the V1 receptor and it's going to solve the problem, right? So this is the second effect of ADH. So there is V1 receptors and there is V2 receptors as well, right? And V2 receptors are responsible for the absorption of water, and V1 receptors are responsible for the um, uh, blood pressure changes. Now we are going to move to the
Dr.
hormone number
Nurse,
two.
just one question. Are V2 receptors also present in distal convoluted tubule as well, apart from
Y-
collecting that?
Yes, so they are present in two areas. They are present in the DCT, which is a distal convoluted tubule, and they are present in the collecting ducts as well, right? So the
Thank you.
important thing that you want to know is that there are two points where, right? So there are a lot of points in the nephron. The one point is proximal convoluted tubule. The other is the descending loop of Henle. Then there is the ascending loop of Henle. Then there is the distal convoluted tubule, and then there is the collecting ducts. Now, each of these parts have different drugs and different hormones that act on these, right? And as we go through this marathon, I'm gonna tell you in each system, whenever we study anything, that which hormones and which drugs are gonna act on which part, right? And we are gonna revise the old ones also, right? So we are gonna keep this in mind. So I told you that on distal convoluted tubule, diuretics are gonna work also, and ADH is gonna work on the distal convoluted tubule and the collecting duct also, right? So this was ADH. Now we are gonna move to another hormone. So remember,
Quick question.
ADH.
Quick question, Dr. Morris.
Yes.
Okay, so you said receptor 1 is found both in the distal convoluted and collecting duct. What about the receptor 1? I know you said it causes vasodilator, but is it also found there? Is it located both at the distal
Okay.
and collecting
Okay.
duct?
Okay, so V1 is present in, so V1 causes vasoconstriction and it's present throughout all the blood vessels in the body, right? So wherever there will be a blood vessel, the V1 receptors are going to be present, right? So again, this is an important concept, right? Where are the V2 receptors present? The V2 receptors are present in the distal convoluted tubule and the collecting ducts. Where are the V1 receptors present? The V1 receptors are present in all of the blood vessels of the body, right? So the blood vessels have V1 receptors, and what other receptors do the blood vessels have? So let's move on to the blood vessels. So the blood vessels have the V1 receptors, they have the alpha 1 receptors, they have the beta 1 and beta 2 receptors as well, right? And what do alpha 1 receptors do? They also cause vasoconstriction, right? What do V1 receptors do? They also cause vasoconstriction, but different drugs are going to act on this. What do beta 2 receptors do? They are going to cause vasodilation, right? Okay.
Yes.
Now we have another hormone which is known as the growth hormone, right?
Thank you.
You're welcome. You're welcome. So we have another hormone now, which is the growth hormone, right? So the growth hormone is a hormone which is secreted from the interior pituitary, right? Now remember, guys, all of the endocrinology is about the hormones, right? So the more of a better grip you have on the hormones, the easier is the endocrinology is going to be, right? The the better the grip is on the hormones, the better is it is going to be for you. So if you know where does the ADH works, what does it do with the solute concentration, what does it causes, how does it interacts with the sodium level, how do it interacts with the water levels, right? The things are going to be easier, right? So the second hormone that we have now is known as the growth hormone, right? So growth hormone is a hormone which is secreted by the anterior pituitary gland, right? So growth hormone is secreted by the anterior pituitary gland. Right. So now this hormone is also known as the somatotropin hormone. Right. Now, what does growth hormones do? Growth hormone is going to increase the growth in your body and it's going to increase the muscle mass. Right. But the problem here is that growth hormone does not act directly on the receptors. Right. I'm going to repeat it again. Direct growth hormone does not increase the growth of the body directly. Right. Whenever growth hormone is secreted, it's going to increase the thing. It's going to increase the level of another thing. Right. Which is known as the IGF, right? So growth hormones are going to increase the level of IGF-1 in the body, right? And it is the IGF-1 through which the patient is going to have. So IGF-1 stands for insulin growth, insulin-like growth factor, right? So the IGF-1 stands for the insulin-like growth factor, and it's gonna cause increased growth stimulation. Now, now an important thing here is that growth hormone also causes another problem. It increases the insulin resistance, right? Growth hormone increases insulin resistance. Now, there are some hormones that increase the insulin resistance. And why are these hormones important? Because whenever a patient is having these hormones excess in the body, the patient is going to have diabetes as well, right? So, usually, diabetes is due to a lack of insulin, right? But sometimes diabetes it can be due to the fact that patient is having insulin resistance. So, there are some hormones that can lead to insulin resistance in the body. One is growth hormone, the other is and this diabetes due to growth hormone and in so if a patient is having an excess of a growth hormone or if a patient is having excess of the cortisol, the patient is going to have very dangerous insulin resistance, right? So these are the diabetogenic hormones. These are the diabetogenic hormones, right? Now, one more important thing
Sorry, quick
regarding
one. Dr. Mohan, you said two hormones that increase insulin resistance. One is growth hormone, the other one is?
cortisol, right? So it's cortisol, right? So whenever you're having cortisol in the body, so cortisols are basically steroids, right? So So it's very simple. So even so, how are the USMLEs going to test these questions too? How do the NBMs put these questions for you? They are going to say that a patient is on. So remember, there are some diseases due to which you have to give a lot of steroids. So for example, if a patient is a patient of systemic lupus erythematosus, or if a patient is having autoimmune disease, right? If a patient is having rheumatoid arthritis, a patient is having celiac disease, right? Or if a patient is having right adrenal crisis, in all of these conditions, you are going to give steroids to the patient. And whenever you give steroids to these patients, what is going to happen is that these patients are going to have diabetogenic effects. Right? These patients are going to have insulin resistance. Right? So these patients are going to have insulin resistance due to which these patients are going to have diabetes. And then they are going to ask you, what is the cause of this diabetes? What is causing diabetes in this patient? So the diabetes in these patients would be attributed to cortisol, or it's going to be attributed to growth hormone if there is an increase in growth hormone, right? So remember this thing: whenever a patient is being treated with steroids, keep diabetes in your mind, and at the same time, so keep osteoporosis in your mind as well if a patient is being treated with steroid, right? Now we would go into the detail of them when you go into the steroid portion, but right now let's focus on growth hormone, right? Now there is a one condition which is known as the IGF resistance, right? Right. What is IGF? So IGF is the middleman of growth hormone. It's the right hand of growth hormone. So growth hormone does not come directly into the body. It's gonna ask the IGF-1 to all of its function. So if there is IGF-1 receptor deficiency, so if there is IGF-1 receptor resistance, the patient is not gonna have any growth, right? If the patient is having IGF-1 deficiency, the patient is not gonna have any growth. Now, one other thing that is very important here is, let me tell you one thing. If a patient is having growth hormone deficiency, the patient is not going to have any growth, right? The patient is not going to have any growth if the patient is having growth hormone deficiency, right? And can any one of you tell me about any famous person? Yes, so that is going to be Lauren dwarfism, right? Do you know about any person, uh, any famous athlete who had growth hormone deficiency and that was cured?
Rey Mysterio.
Any else? Yes,
Messi.
so
Messi.
yes, so that is Lionel Messi, right? So Lionel Messi had growth hormone deficiency, and when he came to Barcelona, he was treated with the growth hormone injections, and he improved, right? So remember, if a patient is having growth hormone deficiency, that patient can be improved, right? Because you are just gonna give growth hormone injections to that patient, and that patient is gonna form the IGF, right? But if a patient is having IGF-1 resistance, right? If the patient's IGF-1 cannot act on the receptors, then the patient cannot be improved, right? And the patient is going to be a dwarf, right? Now, one other thing that is important here is what things cause the secretion of growth hormone? How is growth hormone secretion controlled? So, every hormone has regulatory mechanisms, and we are going to see the regulatory mechanism of all hormones. So keep all of these hormones in your mind, all of these mechanisms. So remember, whenever a patient is sleeping, whenever a patient is sleeping, that is going to increase the growth hormones, right? So that is why whenever athletes train, right, or whenever any person is going bodybuilding, right, so first of all, exercise. So exercise is going to increase growth hormone. So if any patient is exercising, that patient is going to have increased growth hormone. So whenever you are exercising, it is recommended that you sleep as well, because when you will sleep, you will have an increased amount of growth hormone. At the same time, if any patient is in stress, or if any patient is having going through puberty, if any person is going through puberty, that patient is going to have growth hormone secretion as well. Now, one important thing is that hypoglycemia is necessary for growth hormone secretion. And why is that? Why do we need hypoglycemia for the secretion of growth hormone? Remember, if a patient cannot have hypoglycemia, he cannot have growth hormone secretion. Right? Okay, so remember, whenever a patient is having hypoglycemia, the hormone that is released in the body is the insulin, right? And insulin is necessary for the secretion of growth hormone. That is why our bodies are designed in such a way that whenever growth hormone is secreted, there is insulin resistance. So that the insulin stays in the body for long, and there is increased secretion of the growth hormone. So insulin and growth hormone works in hand by hand, right? So that is why we want to have insulin resistance. So whenever there is insulin resistance, the insulin is gonna secrete, stay in the blood for a long amount of time, and now the patient is gonna have increased amount of insulin, and that is gonna lead to increased amount of growth hormone. Now, if you have aging, if you are obese, if you are having hyperglycemia, all of those things are gonna decrease the secretion of growth hormone, right? Now, there are two other things that are important. One is the growth hormone excess, which is known as the acromegaly, right? So now, if a patient is having growth hormone excess during the childhood, the patient is going to have gigantism. Right? We are going to go into the gigantism details when we go into the pathology portion. But right now, if growth hormone is increased during the childhood, the patient is going to have gigantism. Now, if the patient is going to have increased amount of growth hormone in adulthood, the patient is going to get acromegaly. Right? And if the patient does not have enough growth hormone, the patient is going to get dwarfism. Right. Now there are some physiological effect of growth hormone as well. Right. There are some physiological effects of growth hormone, and all of these effects are very important. What are those effects? The number one is growth hormone is gonna increase the amount of insulin resistance. Right. As a result, it's gonna decrease the glucose uptake into the cell. Right. So the glucose uptake into the cell is gonna be decreased. Why? Because what does insulin do? Whenever you're giving insulin to a patient, the thing that is going to happen is that now the patient is not so insulin. Whenever insulin acts on any cell, the glucose uptake that by cell is going to be increased. But if you are having insulin resistance, glucose uptake is not going to be increased by the cell. At the same time, growth hormone is going to cause lipolysis, right? Growth hormone is going to lead to lipolysis. Right? Why is this thing important? This thing is important because if a patient is chronically sleep deprived, if a patient is not having an exercise, right? So remember, you do not need an exercise just to burn calories, right? That is not the only thing you need the exercise for. If a patient is exercising, the patient is having increased growth hormone as well. Whenever you are having increased growth hormone, then what is going to happen is that this patient is going to have increased amount of lipolysis, and you're going to stay fit, right? At the same time, protein synthesis is going to be increased, and at the same time, amino acid intake is going to be increased. These are all the very important mechanisms of actions of growth hormone, right? Now, one important other thing is that IGF-1 is
Can you
also known as,
repeat, Sagar?
what are you saying?
Can you please repeat?
Okay, so I was saying that growth hormone have some physiological effects. What are the physiological effects that the growth hormone has? So the first effect that the growth hormone can has is it is gonna increase the insulin resistance. So when the insulin resistance is gonna increase, the patient's glucose uptake into the cell is gonna decrease. The second thing is that whenever we are doing exercise, we are gonna have increased amount of growth hormone secretion. So that is a very good benefit of exercise, because exercise is not only gonna reduce your calorie burns, it's also going to increase the amount of lipids that are burned. It's going to increase the lipolysis to growth hormone, and it's also going to increase the protein synthesis. It's also going to increase the amino acid uptake, right? Now, one other thing that is important is IGF-1 is also known as the somatostatin, right? IGF-1 is also known as the somatostatin. right? The second thing that is important here is G. How is growth hormone secretion increased? So if a patient is having, so there is a hormone which is known as a GHRH, growth hormone releasing hormone, right? Whenever you are having growth hormone releasing hormone, that is going to increase the secretion of growth hormone. At the same time, we have another hormone which is known as the somatostatin. So we have a hormone which is known as the somatostatin, and it's going to decrease the secretion of growth hormone, right? Now, there is another name for somatostatin, and that is a very common and that is used in real life as well, and that is known as the octreotide, right? So, so we have another name for the somatostatin, and that is known as the octreotide. So whenever a patient is having increased amount of growth hormone, we are going to give the patient octreotide, and that is going to decrease the amount of somatostatin. That is going to decrease the amount of GM growth hormone, right? That is going to decrease the amount of growth hormone, right? Now another important thing here is that whenever we are using steroids for a long amount of time, so if you are using steroids for the past 1 year or 2 year or 3 year, so if you are having a chronic steroid use, now that patient is going to have decreased amount of growth hormone in the body, and when the growth hormone levels are going to be decreased, the fat is going to be increased, the protein synthesis is going to be decreased. That is why whenever a patient of cortisol excess or Cushing syndromes come to you, that patient is going to have very buffalo hump, that patient is going to have an increased amount of fat, and that patient is going to have a decreased amount of protein or muscles in the body. That is why all of these things are happening, right? Now I have not experimentation. Okay, what happens in chronic sleep? Okay, so whenever a patient is having chronic sleep deprivation, the growth hormone levels are going to be decreased, right? There are other physiological changes that are going to be occurring, but the patient is going to have decreased amount of growth. The patient is going to have decreased amount of growth hormone, and then you as an NDMS could ask you that what would be the effect on the lipolysis, what could be the effect on the protein things, right? Now I don't get hypoglycemia growth hormone relationship, right? So remember, growth, so how was the growth hormone, how did growth hormone come into evolution, right? So if you look at the evolution of human beings, if you look at the evolution of animals, one thing is for sure, right? We needed a hormone to get energy, right? So growth hormone was made in our body to get energy from the body, right? It was made to lipolyze the fat, to break the fat and to get the energy from the fat, right? And when do we need the energy from the fat? We need energy from the fat whenever we do not have enough glucose. That is why whenever a patient is having hypoglycemia, the growth hormone is going to come into effect, and the reverse is also true. If we are having hyperglycemia, if we are having increased amount of glucose in the blood, then the thing that is going to happen is that growth hormone is not going to work. It's not going to be secreted. Why? Because the body is going to think this person is already having a lots of energy. This person does not need any more lipolysis to be done. This person does not need any more amount of muscles, so no more growth hormone is going to be secreted. So that is how growth hormone regulation with hypoglycemia works, right? Okay, any more questions? If not, let's move forward. Now let's move to the other hormones. So now we have another hormone which is known as the prolactin. So now we have the prolactin hormone. Now, again, the prolactin is secreted by the anterior pituitary. You have to remember the locations from where these hormones are being secreted. So, the prolactin is going to be secreted by the anterior pituitary gland. Now, what is the function of prolactin? So, the prolactin hormone is very simple. The prolactin hormone is going to increase the secretion of milk in the breast, right? So, prolactin is going to increase the amount of uh, milk in the breast, the production of milk, and at the same time, it's going to increase the breast tissue growth as well, right? It's going to increase the breast tissue growth as well. Now, some things now prolactin relationships are very important, right? A lot of drugs act on the prolactin pathway. So prolactin has its own pathway. Prolactin interacts with a lot of things, and then a lot of drugs interact with prolactin as well, right? So first of all, remember whenever prolactin is secreted, it inhibits another hormone, and that hormone is known as the GnRH. Right? This is a very important hormone of your body because it controls the reproduction, right? It's going to control the reproduction, so this hormone is very important, right? And a lot of relationships are going to revolve around this hormone. And how can we regulate this hormone? What drugs can be given for prolactin or for GnRH, and how do different drugs, especially antipsychotics, affect GnRH and the prolactin? So GnRH is known as the gonadotrophin releasing hormone, right? So whenever GnRH is secreted in the body, you're gonna have increased amount of estrogen, you're gonna have increased amount of testosterone. If you are male, you're gonna have increased amount of progesterone as well, because GnRH is gonna increase the FSH and LH. So GnRH is gonna increase the FSH and LH. So GnRH increases the FSH and LH, and as a result of which, you're gonna have estrogen, you're gonna have testosterone, you're gonna have progesterone as well, right? Now, what does prolactin do? So prolactin is a very bad hormone, right? Prolactin, prolactin is gonna inhibit GnRH secretion, right? So if there is a lot of prolactin in your body, the GnRH secretion is gonna be inhibited, right? And whenever the GnRH secretion is gonna be inhibited, you are gonna have signs of infertility, right? Right. So GnRH is gonna have, you are gonna have infertility, right? You're gonna have infertility, and that is very important. So whenever a patient is having prolactinoma, so that is the first thing when you can have infertility due to prolactin. The second thing is that whenever a patient is pregnant, right, or even after pregnancy, in the pregnancy and even after pregnancy, the patient is gonna have increased amount of prolactin. And what is that increased amount of prolactin gonna do to you? That increased amount of prolactin is gonna decrease the GnRH, right? Now the GnRH is going to be decreases, the FSH and LH is going to be decreased, and when that FSH and LH is going to be decreased, you're not going to get any more estrogen in the body, and that female cannot get pregnant. That is why it is said that breastfeeding is a natural contraceptive, right? So whenever you are breastfeeding, the GnRH is going to be decreased, and when the GnRH is going to be decreased, you are not going to get any FSH and LH, you are not going to get any estrogen, you are not going to have any follicle growth, you are not going to have any ovulation. Remember, this is very important. This is very, very high yield. There are going to be a lot of questions on these in your world, right? So keep this thing in mind. This relationship is a bit difficult, but it is very important. This is very worth it, right? The patient is going to have decreased amount of GnRH secretion whenever the patient is having increased amount of prolactin. And what are the things that can cause increased amount of prolactin? So if a patient is female and the patient is lactating, that patient is going to have increased amount of prolactin, and then all of these things are going to have, right? So when the GnRH is going to be decreased, what are the things that you're going to have in males? So you're going to have ovulation. In the females, you're not going to have any ovulation. You're going to have amenorrhea. You're going to have galactorrhea. You're going to have decreased libido as well. Whereas in males, you are going to have decreased spermatogenesis and you're going to have decreased libido. Right. So this is the first thing that you're going to have there. Now we have some other things regarding prolactin as well, right? So I told you that prolactin, first of all, is going to increase the milk production, is going to decrease the ovulation in female, it's going to decrease the spermatogenesis because it inhibits the GnRH secretion, right? Now, how is the prolactin regulated? So the prolactin is regulated with the help of, so the prolactin is regulated with the help of dopamine, right? So from hypothalamus, you are gonna get dopamine, and that dopamine is gonna inhibit prolactin, right? So if the hypothalamus secretes the dopamine, you're gonna have decreased amount of prolactin. And whenever prolactin is secreted, prolactin increases the amount of dopamine and decreases its own secretion, right? These are the two different concepts. These concepts are important, right? Now I'm going to explain both of these concepts to you, right? Now remember, whenever okay, so there are some other important effects of prolactin as well. We are going to go into these effects as well. But first, so no, prolactin is not going to cause gynecoplasty in males. Yeah, but the interesting fact is that prolactin is going to decrease the gynecomastia in males, right? Prolactin is gonna decrease the gynecomastia in males. Why? Because gynecomastia is caused by estrogen exposure. Right. So whenever a patient is having increased amount of estrogen, that patient is gonna have increased amount of breast tissue, and that is gonna cause gynecomastia in the males. Whenever there is high prolactin, that is gonna decrease the GnRH secretion, and that's not gonna cause gynecomastia. So prolactin was not gonna cause that. But now I told you that whenever a patient is having high dopamine, that patient's prolactin is gonna be decreased. Right. Now, whenever a patient is having schizophrenia, so whenever a patient with schizophrenia or psychotic disorder or any psychiatric disorder comes to you, in a lot of psychiatric disorders, we give the patients an important drugs which are known as the antipsychotics. Right. We are going to cover the antipsychotics in the. Okay, so guys, so remember this point. I have told you these things earlier as well. USMLE is not just a thing of remembrance. It's not just memorizing everything. Right. If it was only memorizing, a lot of people would have just memorized it and gave the exam. Right. It's not about memorizing. It's about integrating the things. Right. Everyone is gonna know about the antipsychotics, but just go to a lot of people who are just given step one, step two, step three, and ask them how do antipsychotics cause increased amount of testosterone, and they are not going to know this. Why? Because you have to integrate the things, right? Whenever you are studying, whenever you are hearing anything from anyone, integrate these things, right? So whenever you are giving any patients antipsychotics have an additional side effect as well. They have a mechanism of action that they are anti-dopaminergic, right? So they are anti-dopamine. So antipsychotics decrease the dopamine in the body, right? And when the dopamine in the body is decreased and they work against the dopamine, what is gonna happen is that prolactin is gonna be increased, right? So prolactin is gonna be increased, and then GnRH is gonna be decreased, and as a result, estrogen and testosterone are gonna be decreased as well, right? So they could ask you, because dopamine inhibits prolactin, and when we are giving a dopamine inhibitor, the prolactin is going to be increased. That is why if a patient is being tested, so they could give you a question that a for 28-year-old female comes to you, and that patient is having galactoria, or that patient is having whitish nipple discharge. That patient is having discharge of whitish fluid from her nipples, and then they could ask you what is the most likely cause of this whitish discharge from the nipple, and then they're going to mention in this her past medical history is significant for schizophrenia, right? And then they could give you a lot of options, and the correct option would be somewhere around the pathophysiology of these things, right? So obviously the patient would have been taking antipsychotics, and the antipsychotics would have been antidopaminergic, and as a result the prolactin level would have been increased in that patient, and then the GnRH levels would be decreased by prolactin, and the testosterone and estrogen would have been decreased, right? So dopamine is very important. Keep this dopamine in your mind. The second thing here is that there is a hormone which is known as the TRH, right? Right. So we have TRH, right? So what does TRH do? TRH increases TSH. So thyrotrophin releasing hormone increases the thyroid stimulating hormone. And when thyroid stimulating hormone increases, it's going to increase the thyroid hormones as well. Now, an important thing that comes here is, for example, so every hormone in the body usually have negative feedback loop. What does that mean? It means if there is an excess of one hormone, it is going to decrease the other hormones, right? So if you are having increased thyroid hormones, then the TSH and TRH are going to be decreased. But if thyroid hormones are low, so for example, if thyroid hormones are low in the body, so if the patient is having hypothyroidism and the thyroid hormones are low, then what is going to happen is that TSH and TRH are gonna be increased, right? And what does TRH do? TRH increases the simulation of prolactin as well. So TRH increases the stimulation of prolactin, and the patient is again gonna have galactoria, right? So this is another important mechanism that occurs in hypothyroidism. So again, a patient of hypothyroidism can have increased amount of prolactin levels, and that patient can have increased amount of so the patient could have increased amount of prolactin levels, and the patient could have galactoria. The patient could have infertility, right? So they could ask you, why does hypothyroidism cause infertility? And if you look at hypothyroidism, you're going to see a lot of patients and a lot of females who are hypothyroid, they cannot have a baby, right? And they could give you a question that a 31-year-old female comes to you and that patient is not able to conceive for the past 1 or 2 years, right? He has tried every single thing, but she has failed, right? Now they could say you that the patient is also having cold intolerance. The patient cannot stay in the cold and the patient is having very low heartbeat, right? The heart rate is very low, the patient is having cold intolerance, and then they could ask you, what is the why is this thing most likely happening? Why is this patient having infertility, right? And then you're gonna say, what the heck does these things what do these things have to do with the what does infertility have to do to within cold intolerance, right? So whenever a patient is having cold intolerance, the patient is having constipation, the patient is having any of those symptoms, then most likely the patient is also going to have mm, hypothyroidism, right? These are all the signs and symptoms of hypothyroidism. And when the patient is having hypothyroidism, the TRH levels are going to be increased. And when the TRH levels are going to be increased, then you are going to have increased amount of prolactin, and that is going to cause you decreased amount of GnRH and the infertility and the decreased libido and all of those things. Now we have some dopamine agonists, right? So whenever we have Parkinson disease, we can use. So whenever we, so there are some dopamine agonists. What are the dopamine agonists? These are bromocriptine and cabergoline, right? So these are bromocriptine and cabergoline. So whenever we give these to patients, the level of prolactins are going to be decreased. So if a patient is having prolactinoma, which is a tumor that is going to cause increased secretion of prolactin, we can just give the patient bromocriptine or cabergoline. So dopamine levels are going to be increased, and when the amount of dopamine levels are going to be increased, the patient is going to have decreased amount of prolactin, right? And that is going to solve the prolactin. So remember, for the treatment of growth hormone excess, we were giving the patient octreotide, and that was a somatostatin analog. Okay. So we were giving the patient octreotide, and that was a somatostatin analog, and that was decreasing growth hormone levels. Whereas in the case of prolactinoma, we are giving the patients dopamine, right? So in the case of prolactinoma, we are giving the patients dopamine, and that is going to inhibit the secretion of dopamine, right? Now, I have told you most antipsychotics are antidopaminergic and they decrease the level of prolactin, right? At the same, and they increase the level of prolactin, right? And at the same time, there is another drug which is known as the metoclopramide, right? So metoclopramide is used for two things. It's used for nausea. So if a patient is having nausea or vomiting, we use metoclopramide. And if the patient is having diabetic gastroparesis, so if a patient is having diabetic gastroparesis, then we use metoclopramide as well, right? And then this thing is gonna increase the uh, again, this is an anti-dopaminergic. So if, for example, if they give you a question that a 45-year-old or 43-year-old female comes to you and that patient is having difficulty digesting food, right? Because that is what will happen in diabetic gastroparesis, and then they say to you that this patient is having difficulty digesting food and she has a history of diabetes. Now you have given this patient a drug to increase to relieve her symptoms, and now the patient's symptoms are relieved. But now 2 months later, the patient returns to you and that patient is having infertility or that patient is having galactoria. And what is the most likely mechanism of this thing? So the most likely thing will be that metoclopramide is an anti-dopaminergic, and that anti-dopaminergic is gonna cause uh, increase prolactin secretion, right? So remember, prolactin is very important. I'm repeating it again and again, right? Can you repeat the pregnancy scenario? Okay, so I was saying that if a female wants to get pregnant, right? So if a female comes to you and that female wants to get pregnant, but that female is not getting pregnant, and at the same time that female is having cold intolerance, uh the patient is feeling very cold, right? And the patient cannot is having very low heartbeat, then the patient is most likely going to have hypothyroidism, right? And that hypothyroidism would be a very likely cause of this patient's inability to conceive or get pregnant. Why? Because hypothyroidism is going to increase the TRS and TSH level, and when TRS and TSH level are going to be increased, then this patient is going to have increased amount of prolactin, and then that is going to cause decreased amount of GnRH, and that GnRH is going to lead to increased amount of a decreased amount of estrogen and FSH and LH and decreased amount of estrogen. Right? Yes. So Bromocriptine. Okay, so bromocriptine. Okay, so let's move to bromocriptine. So bromocriptine is a drug which is a dopamine analog, right? So it works on the dopamine receptors. So wherever there are dopamine receptors in the body, bromocriptine is going to act on those receptors, right? So wherever there are dopamine receptors in the body, bromocriptine is going to act on those receptors, right? And dopamine receptors are also present in the anterior pituitary, right? So if this is the anterior pituitary, this is the anterior pituitary, there are dopamine receptors here. So bromocriptine is going to bind on these dopamine receptors, and then what's it is going to cause the prolactin level to decrease, right? And when the prolactin levels are going to decrease, then the patient's prolactinoma is going to be solved. So prolactinoma means a tumor that is having high amount of prolactin. So that is how dopamine. So that is how the bromocriptine and cabergoline, both of these are gonna work, right? Now there are some side effects of bromocriptine and cabergoline. Those are very important as well. What are those side effects? So any dopamine agonist has a very important side effect that it would lead to impulse control disorder. Right. So what is impulse control disorder? Now again, I am telling you these things here. These things are related to the neurology. So the impulse control disorders is related to the neurology. But why am I what? But why am I telling you these things here? I am telling you these things here because impulse control disorder is not only linked to the neurology. They're not going to give you a neurology question and then they are going to ask in impulse control disorder. They're most going to give you a endocrinology or reproductive question with a prolactinoma and then they're going to ask you about impulse control disorder. So impulse control disorder means that the patient does not have any controls on his impulses. That patient is going to have sexual perversions. That patient is going to spend a lot of money in the public. That patient is going to sell all of his lands or all of his properties, or that patient is going to lose all of his monies in the gambling, right? So this is known as the impulse control disorder, and this is present in the patients who are being treated with bromocriptine or cabergoline. If the patient is being treated with amidopamine agonist, that patient could have impulse control disorder. So, for example, if they give you a question that if a 37-year-old female comes to you and that patient is having a prolactinoma, right? That patient is having galactoria, and for that galactoria, you give the patient a treatment. And all of a sudden, the galactoria has improved a lot. But now the female went to a shopping mall and she spent all of the credit card to buy $10,000 or $15,000 worth of dresses, right? And then the women went to a casino and she spent all of the credit cards money in the casino, right? So what is the mechanism of action of the drug that was given to this patient? So the mechanism of action would most likely be a dopamine agonism, right? Now what is octreotide? So basically we have a drug in our body which is known as the somatostatin, right? So what does somatostatin do? So somatostatin reduces the secretion of growth hormone, right? Somatostatin reduces the secretion of growth hormone. It also reduces the secretion of a lot of other drugs as well. It's going to reduce the secretion of insulin. It's going to reduce the secretion of glucagon. It's going to reduce the secretion of cholecystokinin as well, right? It's going to act on the thyroid stimulating hormone as well. But right now we are focused on growth hormone. So somatostatin is going to decrease the secretion of growth hormone, right? So if a patient is having growth hormone, a increased amount of growth hormone due to any tumor, right? So any tumor in the pituitary is known as the pituitary adenoma. So if a patient is having any pituitary adenoma that is secreting growth hormone, we have to stop that pituitary adenoma, right? And how do we stop that pituitary adenoma? In order to stop that pituitary adenoma, we can give the patient an analog. Analog means a drug which is very similar to the original hormone and it acts on the same receptors, right? So we are gonna give the patient an analog of somatostatin, that is octreotide, and that thing is gonna stop the secretion of growth hormone. Now another thing, there are a lot of pituitary adenomas. So there could be a thyrotrophin releasing pituitary adenoma, there could be growth hormone secreting pituitary adenoma, there could be prolactin secreting pituitary adenoma. The treatment of all the pituitary adenomas is surgical removal, except for one, and that is the prolactin secreting pituitary adenoma, which is known as the prolactinoma. Why? Because for prolactinoma, we can give the patients dopamine agonists, and that dopamine agonists are very, very, very effective in the treatment of prolactinoma. So for prolactinoma, the first line treatment, the standard treatment is bromocriptine and cabergoline, which are the dopamine agonists. For other pituitary adenomas, the first line treatment is surgical removal, and even if after surgical removal they are present, then we can give octreotide for growth hormone, and for other hormones we can give their respective drugs, right? So okay, so guys, that was from my side today. So we have done the half the amount of drugs, half the amount of hormones today. The rest of the hormones are going to be done tomorrow, right? So we are going to complete the physiology tomorrow, and then we are going to start the pathology, right?
Thank you,
Yes,
Doc.
so it's going. You're welcome. So yes, it's going to help in carcinoid syndrome too. As I told you, it's secretin, so it helps in a lot of scenarios. It's going to reduce the secretion of lot of hormones. As we go over all of those hormones, we are going to cover those one by one. Okay, guys. So take care and bye bye. We will do an no, no. I will cover the embryology and anatomy as well, right? But the embryo and anatomy is very simple. It's gonna take maximum 10 to 15 minutes, right? So whenever we are gonna do thyroid, I'm gonna do the anatomy of the thyroid first, and then we're gonna move the pathology portion of that, right? Welcome. Oh, you're welcome, Dr. Aksar. You're welcome, Dr. Umar.
Is Dr. Ahmed going to come?
Yeah, I believe so eventually.
Yeah, okay. Just wait.
Guys, I think we have to leave and then come back in so that they can get the recording of the class we just had. Thank you.
But Dr. Hamza messaged in the group that Dr. Ahmad was going to start the bootcamp in 5 minutes.
So the boot camp is going to start or we have to leave?
I talked to Dr. Hamza and he said it's the same link. So now I'm not too sure what's going on.
Hey, Shaz, could you like ask him if we need to? He said same link, but do they want us to like leave and come back? Because earlier on he said we should leave, so it's like kind of confusing.
Yeah, I'll text him again.
We just texted him and Dr. Hamza said that the session will be continued in the same link. So we do not have to leave.
Okay, thank you.
Okay, thanks.
Did everybody just get back in, or were you still here from the previous class?
I
I
just
have an
came back.
idea.
I just
How
came back.
about I
Did
have an
everybody get off?
I have an idea. How about we all just leave the meeting and then rejoin it so that
Yes,
the
because
previous meeting got
otherwise,
recording?
we won't get the recording on time. So
Yes,
please,
let's do
everybody
this.
get
That's
off
true.
and then
Dr.
get back
Hamza,
Yeah.
on. Thank
Dr.
you.
Hamza just messaged in the group and he said that we will be using the same link for Dr. Ahmed's lecture.
But we can always join.
Yeah. So
Oh,
everybody close and
we
then
can
just
always sign
join
off and
back.
come back so that this
Yes.
one can yes.
Yeah,
Thank
All
you.
right.
What's their
just
pre-session?
close.
Yeah.
Sounds good.
We can come back when Dr. Ahmed asks
Yes,
us to come
yes.
back. We can come back.
When he
Yeah.
sends us a message in the group that we come back, then we can all
Yeah,
sign
good.
back in.
Thank
All
you,
right.
everyone.
Okay, let's click the red button. 1, 2, 3.
This is hilarious.
Hello? Hello? Can you guys hear me? Hello?
Yes.
Okay, that's perfect. So we're about to start our session. I would say in 5 minutes, we are having a break session. So can you just please drop down our text in the group so that maximum students should just join this meeting, okay? So,
Hey, Dr. Ahmed, like everybody leaving so that we could get the recording process for the first one and
okay,
then we
okay,
will
no
come
problem.
back.
Okay, you
So
should
could
just
we all like leave and then come back in like a few minutes?
okay, that's great. So you guys should then leave the meeting. I'll just send a new meeting. Okay, so please everyone leave this meeting, okay, so that I can get recording of this session. Thank you so much.
All right, bye.
Kindly leave this meeting. I'm just sending you a new link. Kindly leave this meeting and join the new link so that we can get the recording, please.
Amjad, is the thing on? What are they saying on that group? I'm just so confused. I don't know why we keep joining and rejoining.
There is another link in the group.
There's another link. Okay. Amjad, send me the link.